Let's now apply these methods using clinical examples. Case 1. The chest X-ray of this patient is first shown. Both lungs look fairly wet, and an ultrasound study will help to assess and semi-quantify the amount of pleural fluid. A longitudinal scan is performed in the right posterior axillary line and demonstrates a large right pleural effusion. Just looking at it, we know subjectively that the effusion is significant. However, let's perform a semi-quantitative assessment of the effusion using the methods previously reviewed. From the longitudinal view, the probe is turned 90 degrees clockwise to obtain a transverse view of the chest. Let's take a moment to review the anatomical perspective of this plane. In the transverse plane, the view obtained is analogous to that of a CT scan as was previously seen. Let's rotate this image to position it as it appears on the ultrasound system screen by doing a clockwise rotation. This view corresponds to the schematic view previously described when reviewing the studies on effusion quantification, with the posterolateral aspect of the lung and chest wall visualized in the proximal part of the screen. Shown here is the axial CT scan of our patient, obtained in the lower aspect of the chest. We can identify the right and left lung that have atelectasis at their base, and we can identify two bilateral large pleural effusions. Let's now position the ultrasound probe in the posterolateral aspect of the right chest. We then rotate the whole picture to position it as it will appear on the ultrasound system screen by doing a clockwise rotation. If we focus our attention on what will be visualized in the ultrasound scan plane, we are left with this view in which we can see the atelectatic lung and large pleural effusion. Based on the two studies previously reviewed, the maximal interpleural distance occupied by fluid needs to be measured in this view between the posterior aspect of the atelectatic lung and the posterior chest wall. Let's now have a look at the real ultrasound view of this patient's right chest in the transverse plane. We can here identify the posterolateral chest wall, the atelectatic lung, the posterior inner chest wall, and the large pleural effusion. The maximal interpleural distance is measured at 70 mm. Based on the study of Vignon et al., as our interpleural distance on the right is more than 45 mm, we know with a high level of certainty that the pleural effusion is of a volume more than 800 milliliter, and that it is thus very safe to tap it if clinically indicated. Based on the Balik et al. Method, the volume of pleural fluid is estimated using the formula 20 times the maximal separation distance between the two pleura, which is 70 mm in this case. The result is an estimated pleural effusion volume of 1.4 liter.